Hello, anesthesiologists. Welcome to today's episode of Anesthesia and Perioperative Medicine. Today we'll discuss anesthesia for a patient with a positive antibody screening test, something you experienced during your residency.
Bonjour, chers anesthesiologistes. Bienvenue dans cet épisode d'anesthésie et médecine périopératoire. Aujourd'hui, nous aborderons la prise en charge anesthésique d'un patient présentant un test de dépistage d'anticorps positif, une situation que vous avez certainement rencontrée durant votre internat.
All right, so here's our game plan. We're going to start with a basic science, what's actually happening on a cellular level. Then we'll figure out who is most at risk. We'll look at the clinical signs you need to watch for post-op, and then we'll get into the real meat of it, the practical protocols for pre-op, intra-op, and post-op care. And we'll wrap up by looking at where the science is headed.
So let's kick things off with the immunological challenge. We all know about ABO blood types, right? Well, this is where we go a level deeper into the complexities that can create some really serious risks for our patients, especially those who've had transfusions or pregnancies in the past.
I mean, think about that question for a second. This is the whole idea behind red cell alloimmunization. We're not talking about an immediate, obvious mismatch here. It's a much sneakier process where a perfectly successful transfusion today can actually prime the patient's immune system to launch an attack on future transfusions. It's basically training the body to reject the very thing that's supposed to save it.
So what's happening is that the patient's immune system creates a memory against certain red cell proteins that it doesn't have itself. This happens anytime they're exposed to blood that has these foreign antigens. These new antibodies, the alloantibodies, can then just hang out, sometimes for years, completely dormant, until the next exposure. And that's when they can wake up and cause some really devastating problems.
Okay, so this table lays out the main players beyond the familiar ABO and RHD system. Now, they're all important, but I really want to draw your eye to one in particular, the KID system. Look at that description, disappearing antibodies. This is exactly why we call anti-JKA and JKB the dangerous antibodies. Their levels in the blood can actually drop so low over time that a patient's pre-op antibody screen comes back negative. This gives you a totally false sense of security. Then you transfuse them, they get re-exposed, and bam, the immune system launches a really fast and furious attack. The other systems are critical too, of course. R is the most common cause of alloimmunization, Kel is super immunogenic, but it's that sneaky, treacherous nature of the KID system that every single one of us needs to have a healthy respect for.
So how does this whole sensitization process work? Well, it all starts with exposure to a foreign antigen. The main action happens in the spleen, where these specialized immune cells called antigen-presenting cells, or APCs, basically gobble up the foreign red cells. They then chop them up and present little pieces of those foreign antigens to another key player, the helper T cells. This interaction is like the secret handshake that kicks the whole adaptive immune response into gear. This leads to B cells maturing into plasma cells that just start churning out those problematic IgG antibodies. And, maybe even more importantly, they create these long-lived memory B cells that just lie in wait. Now, this slide gets into the deep science, but here's the clinical takeaway you really need. You've got two main pathways. The one on the left, the T-cell-dependent pathway, that's the one we are really concerned about. Think of it as the high-alert pathway. It requires that critical T-cell involvement, and that's what leads to the creation of these powerful, long-lasting IgG antibodies and a really strong immunologic memory. This is the pathway that sets the stage for those dangerous delayed reactions that we're trying so hard to prevent.
And here is an absolutely fundamental point. If you transfuse a patient when they are in a state of inflammation, think sepsis, major trauma, or a vaso-occlusive crisis in a sickle cell patient, you dramatically increase the risk of them forming these antibodies. Inflammation basically acts like a danger signal to the immune system. It supercharges the ability of those APCs to process and present the foreign antigens, effectively lowering the bar for an immune response to get started. It can turn a patient who might have been tolerant, a non-responder, into a responder.
This comparison is so important for our clinical practice. An acute ABO reaction is a bomb going off right in front of you. It's an immediate intravascular catastrophe driven by pre-existing IgM antibodies. You see massive complement activation, shock, DIC right there in the OR. A delayed reaction, on the other hand, is completely different. It's insidious. It's a slow burn, driven by IgG antibodies happening days or even weeks later. And the hemolysis is mostly extravascular, happening quietly inside the spleen and liver. The symptoms are subtle: an unexplained drop in hemoglobin, a low-grade fever, maybe some jaundice. It's a totally different beast, but believe me, it can be just as deadly.
Okay, so we've got the mechanism down. Now let's switch gears and focus on the who. Which of our patients are walking into the OR already susceptible to developing these dangerous antibodies? Because understanding these risk factors is really our first line of defense.
You can see right away that patients with underlying inflammatory and hematologic diseases are at incredibly high risk. Just look at the rates for thalassemia and especially for sickle cell disease. They're staggering, up to 50% in some studies. This isn't just a random chance. It's because these conditions create the absolute perfect storm for alloimmunization. You've got chronic inflammation combined with the need for repeated transfusions.
The risk is really a mix of different factors. It starts with the patient themselves. Their underlying disease is already creating that inflammatory environment, and their personal genetics might just predispose them to have a stronger immune response. Then you layer on the transfusion-related factors. The sheer number of units they receive is a huge driver, of course, but what's really critical is the degree of mismatch. And this gets amplified by ethnic disparities in the blood supply. For example, a patient with sickle cell disease who is of African descent has a very different red cell antigen profile than our predominantly Caucasian donor pool. This just increases the odds of them being exposed to multiple foreign antigens with every single unit they get. This image just drives home that point about the complex web of factors. It's a great reminder for us that when we're assessing risk, we can't just be thinking about the blood product itself. We have to take into account the entire clinical picture of our patient.
And this brings us to a really fascinating idea. It turns out some people are just genetically wired to mount a more powerful immune response to foreign antigens. We call this the good responder phenotype. These are the patients who, even with just a little bit of exposure, are far more likely to form alloantibodies, and often they'll form multiple different alloantibodies. Now, this table shows us something that's clinically really powerful. We can actually start to link a patient's specific genetics to their risk of making specific antibodies. The one I want you to notice here is the allele HLA-DRB115. You can see it's linked to a few different antibodies, but the big takeaway is that it's strongly associated with patients who form multiple antibodies. These are our multi-responders. This is a huge deal because it suggests that someday we might be able to use HLA typing to predict a patient's risk before they ever get their very first transfusion. Okay, so now let's focus on what these reactions actually look like. What are we going to see at the bedside? What will the labs show? These are the critical signs and symptoms we have to be able to recognize to protect our patients both in the OR and on the floor.
So DHTR is the classic way this problem presents, and a key phrase here is amnestic response. That's just the medical term for a really fast and powerful secondary immune reaction. It means the patient has been sensitized before. Their initial antibody level might have faded over time to become undetectable, so their pre-transfusion screen is negative. But when you re-expose them to that same antigen, their memory B cells reactivate almost instantly, producing a flood of IgG antibodies that go on the attack against those newly transfused cells. This timeline really highlights the delayed nature of the threat. On day 0, in the operating room, everything looks totally fine. The real danger starts to emerge on post-op day 3, or 5, or even 7, when the patient spikes a new fever or their hemoglobin, which you'd expect to be stable or rising, just inexplicably starts to drop. By the time the hemolysis really peaks, around days 7 to 14, the lab picture becomes crystal clear. Their direct antiglobulin test, the DAT, flips to positive, a new antibody shows up, and all the markers of hemolysis, like LDH and bilirubin, are elevated while haptoglobin gets all used up. Hyperhemolysis is the absolute nightmare scenario. It's a rare but truly catastrophic escalation of a DHTR, and we see it most often in our patients with sickle cell disease. For reasons we don't totally understand, the immune response just goes into overdrive. It not only destroys the foreign transfused cells, but it also starts destroying the patient's own native red cells as innocent bystanders. The result is this devastating paradoxical anemia, where the hemoglobin actually falls lower than it was before you gave the transfusion. This is a critical do not transfuse further situation. Giving more blood will only fuel the fire. Okay, so now we're getting to the really practical stuff, the anesthesiologist playbook. You have a patient on your schedule for tomorrow, and you see they have a positive antibody screen. What do you do? This is where proactive, careful planning is absolutely everything. The second you see that positive screen, a specific protocol has to kick in immediately. The clock starts ticking right then. Step 1 is just recognizing it in the pre-op evaluation. Step 2 is communication. You need to pick up the phone and call the transfusion service. They have to run an identification panel to figure out exactly which antibody it is. Step 3 is procurement, and honestly, this is the rate-limiting step. Finding units of blood that don't have that specific antigen can be a massive logistical headache. For a common antibody, maybe it takes a few hours. For a rare one, it could take days, even weeks. And that leads directly to step 4,
we have to adjust our plan. We simply cannot safely proceed with the surgery until we have confirmation that compatible blood is physically in the hospital. So here's the bottom line. For an elective case with any significant risk of bleeding, we cannot proceed until these boxes are checked. We have to know, has the antibody been identified? And critically, how many compatible units are physically on the shelf in our blood bank? That number dictates our entire conversation with the surgeon. If you only have 2 units available for a major spine fusion, the safest decision for the patient might be to postpone. And from the very start, patient blood management has to be the central pillar of our entire plan. All right, let's move into our house, the intraoperative and immediate postoperative periods. This is where our decisions about fluid management, bleeding control, and when to pull the trigger on a transfusion have the most immediate and profound impact. For these patients, patient blood management isn't just a good idea, it's an absolute lifeline. We have to deploy every single tool in our PBM toolkit. That starts with working with the surgeon to ensure meticulous hemostasis. It means using antifibrinolytics like TXA. Cell salvage is your best friend here because the patient's own blood is, of course, perfectly antigen matched. We have to be incredibly disciplined with our transfusion triggers, tolerating lower hemoglobin levels as long as the patient is physiologically handling it, and using TEG or ROTEM is key because it allows us to precisely correct a coagulopathy with specific factors, instead of just empirically giving FFP or platelet. This mantra right here should guide every single decision we make in the OR. Our entire goal shifts from just replacing blood loss to preventing blood loss from ever happening in the first place. Why? Because finding that compatible unit is a struggle, and even when you get it, transfusing it still carries risk. So what happens when things go wrong and you're in the middle of a massive hemorrhage? Our standard protocols have to be modified. Yes, we activate the MTP, but we have to clearly communicate to the blood bank that this is an alloimmunized patient. Our first move should be damage control resuscitation, using vasopressors and fluids to buy time while the surgeons get control of the bleeding. If we burn through our supply of antigen-negative units and the patient is still exsanguinating, we are forced into a terrible risk-benefit calculation. At that point, the blood bank may issue what's called least incompatible blood. This is truly a life-saving measure of last resort. And here is a critical warning. Do not fall into the O-negative trap. Reaching for that emergency O-neg blood is the absolute wrong move here, because it is almost certainly positive for the very antigen the patient has an antibody against. You know, in surgeries with massive expected blood loss, like a liver transplant, the whole strategy is different. Here, trying to avoid transfusion just isn't realistic. So the preoperative phase becomes everything. We're talking about weeks of planning, maybe even plasmapheresis to lower the antibody levels, and securing a huge inventory of antigen-negative blood before that patient ever even comes to the operating room. The strategy completely shifts from avoidance to meticulous, exhaustive preparation. Our responsibility does not end when the patient leaves the PACU. This monitoring protocol is a critical tool that needs to be part of our handover to the surgical and ICU teams. Daily hemoglobin checks for that first week are absolutely essential, and you're looking for that unexpected drop. This should be combined with periodic checks of hemolysis labs at key time points, like days 3, 7, and 14. And honestly, simple clinical observation of their urine color and asking about new symptoms like fever can be the very earliest signs that a DHTR is brewing. If you suspect a DHTR, the response has to be fast and coordinated. The first and most important step is to stop any further transfusions. Immediately get the blood bank on the phone and send them a new sample. They've got to repeat the entire antibody workup to confirm the diagnosis. While that's happening, you need to start supportive care like hydration. For the really severe cases, this becomes a multidisciplinary effort with hematology. And you might be talking about immunosuppressive therapies like steroids or IVIG to try and calm down that runaway immune response. Okay, let's wrap this up by looking at some of the cool science that's shaping the future of transfusing medicine, and then summarize our core anesthetic strategy for managing these really complex patients. The research happening in this area is incredibly exciting. Scientists are really trying to answer that core question: what is it that determines who becomes a responder? They're looking beyond the classic HLA types to understand the subtle genetic and molecular switches that control immune tolerance, things like the role of regulatory T cells in the complement system. The ultimate goal here is to get away from a one-size-fits-all approach and move toward a truly personalized transfusion medicine. I mean, the ultimate goal is to shift from reactive management, where we're just dealing with antibodies after they've already formed, to proactive prevention. With advanced, high-throughput genotyping, we could know a patient's entire red cell antigen profile and their immunogenic risk profile from a single blood sample.
This would let us provide perfectly matched blood from the very first transfusion, which could potentially prevent alloimmunization from ever happening in the first place.
So, to bring this all home, here is your 4-part strategy for your clinical practice. Probe, be the detective in that pre-op clinic who catches the positive screen and asks the right questions. Plan, be the coordinator who gets the blood bank and the surgeons on the same page to create a safe plan. Practice PBM, be that vigilant clinician in the OR who conserves every single drop of blood. And finally, protect, be the physician who makes sure a robust post-op monitoring plan is in place and followed. By really embracing this comprehensive approach, we can safely navigate the complex challenges of red cell alloimmunization and give our patients the absolute best care possible.